Thank you very much for having me to speak. As Al was saying, I work for Children's National Health System and a subsidiary of Children's National in Inova, and also we're affiliated with GW University here. I work some in neurogenetics and with epilepsy. My training is in epilepsy and EEG, and I see kids who have refractory epilepsy, intractable seizures, and including many patients who have genetically mediated epilepsies. So I want to make this interactive today. I think I'm going to touch on most topics. I hope I've anticipated some questions here. So please feel free to raise your hand, ask questions throughout this. I may hold your question until later because, like I said, I do try to cover a lot here. And we'll try to get through all that now, okay? I have no relevant disclosures. So we'll talk about seizure and epilepsy terminology, just so you know what your neurologist is talking about when they bring up seizure type, epilepsy type, and why we choose the medicines we do to treat. Talk about seizures and epilepsy specifically in Mowat-Wilson syndrome, the evaluation that we perform for seizures typically, and then discuss management, medications, other management. I've already had some questions about CBD oil, hemp oil, cannabidiol, medical marijuana, so I'll definitely get into that. And then talk about epilepsy comorbidities and complications that we encounter. So just some definitions. A seizure is, this is from the Institute on Medicine report in 2014, that defines seizures and epilepsy. So just so we know what we're talking about. A seizure is a disturbance in the electrical activity of the brain that is associated with a clinical change. I'll show you some electroencephalograms, but what this looks like on an EEG, typically during a seizure, you'll see a change in the electrical activity of the brain associated with that behavioral change or that sensation. And there is an evolution, a change in that EEG that progresses with that clinical change. Epilepsy is just 2 or more unprovoked seizures separated by more than 24 hours. So if you have a couple seizures within a short period, we don't necessarily call that epilepsy. There's been a movement recently to change the definition of epilepsy into saying that if you have had one seizure and then the probability of having additional seizures is more than 75%. Well, how do you calculate that? For most people, we don't really know. The EEG can help with future risk for seizures. In general, if you've had 2 seizures, your chance of having more is around 80% or higher. So that's why we use that epilepsy definition once you've had 2 seizures. But in Mowat-Wilson syndrome, I think this definition is probably appropriate. If you've had 1 seizure and you have Mowat-Wilson syndrome, I think it's reasonable to say that this person has epilepsy, and therefore you may want to consider starting treatment after 1 seizure. So epilepsy overall affects over 2 million people in the US and more than 65 million people worldwide. Each year there's 150,000 new cases of epilepsy diagnosed annually in the US, and 1 in 26 people in the US will develop epilepsy at some point in their lifetime. So it's a fairly prevalent disorder. This again is just epilepsy overall. And if you look at the overall burden of disease among neurological diseases, it's the 4th most common. You can see here behind migraine, stroke, and Alzheimer's. And the difference between this and stroke and Alzheimer's is it affects people over a much larger span of their life. So we classify seizures and epilepsy in different ways. Seizures are described as those of focal onset, meaning they just start in one part of the brain. Those with generalized onset appearing to start all over the brain at once if you look at them on the EEG, that electroencephalogram, and those with unknown onset. So, and we can break down focal seizures into different types. Focal seizures where you're aware, where you're conscious and cognizant of what's going on, and those that cause impaired awareness. And the difference here is in what part of the brain is affected during that focal seizure and how large an area of the brain is impacted by that focal seizure. If it involves a large enough area of the brain, you're going to lose that awareness. Not necessarily lose consciousness. You won't be fully passed out and out of it necessarily, but you may just not be fully aware. You might have confusion. You might not be completely or normally responsive. Focal seizures can look a variety of different ways, and I stress this because this is one of the main seizure types, as you probably know, in Mowat-Wilson syndrome. These children and adults frequently have focal seizures. So you can have focal motor seizures, motor onset with shaking, with jerking of one extremity, with abnormal hyperkinetic movements, bicycling of the legs. They can look a lot of different ways. Tonic seizures where you stiffen, myoclonic seizures where you might just jerk repetitively. The question? Right. Exactly. So the older definitions were that's a good point. Focal versus partial. So focal equals partial, and complex means that there's an alteration in awareness. So the old terminology, which people still use, so you're not wrong to call them a complex partial seizure, and if you hear someone use that terminology, that's perfectly acceptable. But a complex partial seizure equates to a focal unaware seizure in this new terminology. Thank you. And you can have those focal seizures with non-motor onset, so you can just have autonomic symptoms. You can have prolonged confusion, vomiting, flushing, pupillary dilatation, behavioral arrest where you just stop and pause for a long period of time, various sensations, those types of changes. And focal seizures can evolve, they can spread, and they can generalize and turn into a grand mal seizure. But some of those characteristics, if someone starts off with jerking in one extremity, one side of the body, and then turns into a generalized tonic-clonic seizure or a grand mal seizure, then we classify that as a seizure of focal onset. This distinction is important because it helps us to decide which medications to choose for that epilepsy type. Seizures of generalized onset. The main one I'll focus on here are absence seizures. And absence seizures look kind of like complex partial seizures, those focal unaware seizures, except the typical absence seizures are just brief staring spells. They're just a brief pause, a complete arrest in activity. People are unaware of what's going on around them, lasting usually just a few seconds, 10, 15 seconds, longest maybe 40 seconds, and then return to baseline immediately afterwards. Yes?
What I have heard, because my son has no seizures, is that in Mowat-Wilson, they commonly have the absence seizures. So how do you know if he's having the seizure? And actually, most of you are talking about when they are sleeping. How do you know
Right.
if you sleep in another room, so you cannot know if he's having one?
Yeah, so I'll get into the sleep and seizure issue a little bit later on too, but this is a very good question about how do you identify these absence seizures, because in Mowat-Wilson syndrome they're usually atypical absence seizures, and atypical absence seizures are different in that there's often no clear onset and offset. In a classic absence seizure, people just stare like that. They just have a spell. This absence seizure interrupts their activity. They're in the middle of doing something, and they just stop. They're completely unresponsive, and then they resume that normal activity. For atypical absence, it's not as distinct an onset and offset. And they may not have a complete lack of awareness either during the seizure. So they might look at you, they might nod, they might, still be able to respond to some degree during that atypical absence seizure. It can also last longer. So unlike the classic absence seizures that last 10 seconds, these atypical absence seizures can go on for much longer, sometimes even minutes. The other thing is the EEG appearance is a bit different. That's not something that you really need to know about so much, but is important for your neurologist to know about, is that they can look a little bit different on the electroencephalogram during that seizure. So then how do you know if your child is having an absence seizure or atypical absence seizure? Well, sometimes it's hard The gold standard for diagnosis is to do an electroencephalogram, to do an EEG, and record any episodes of concern on that EEG, because that should be abnormal. If you have a seizure that produces some kind of alteration in your awareness, you should see something on that EEG during that event. Many times you may not be able to catch that if it's not occurring frequently enough. So EEG can still be useful to see if you are having subtle seizures, subclinical seizures. But I would also tell you that a lot of kids stare. Certainly, kids with Mowat-Wilson syndrome and other genetic conditions can stare. If you call their name, they won't often respond to you anyway. If you go and tickle someone, tap them on the shoulder, try to bring them out of it in that way, and they don't come out of it, then I would wonder if that was a seizure. If they're happening frequently enough, then I think it's worth doing an EEG to try to record an event. If they're not happening all that frequently, I think in general what I tell people is to try to go interrupt that staring spell, not just by calling someone's name or waving your hand in their face, but by tickling them or doing something else that is going to draw their attention. I got a question in the back there.
So we've done an EEG and there is abnormal activity or atypical activity, but our neurologist at this point doesn't think that it needs to be medicated. Would that be a typical response from a neurologist? Or if you see abnormal activity, does that automatically equal some form of intervention with drugs?
So abnormal activity does not equal intervention. That's a good point too. So just because you have abnormal activity there doesn't mean you need to treat. There's lots of different kinds of epilepsy or genetic syndromes that are associated with epilepsy where kids can have an abnormal EEG and actually never have a seizure even. So it is possible. But that's a situation in which I might watch a kid more closely. Yes?
With the atypical absent seizures, you mentioned tickling or trying to snap out of it. Does that, if an MWS child is having that, will that snap them out of it?
If it's an absent seizure, an atypical absent seizure, they won't respond normally to you if you do that. You can't stop a seizure without some kind of medication. Yeah. Okay, all very good questions. Thank you. Just to get through a couple other seizure types that you might see, Mowat-Wilson syndrome is known to be associated also with myoclonic seizures. So there's tonic seizures, which are stiffening, and they're usually kind of slow stiffening of various types. You can have focal stiffening on one side, on the other side, or all over. You have clonic rhythmic jerking, where you kind of have a fast phase and a relaxation phase. And then there's myoclonic seizures, which are more erratic, irregular jerks, which might occur in various body parts or might occur all over. Sometimes they can exist with atonic or drop seizures. They might make you fall, they might make you contract forward. They don't occur rhythmically, but they do frequently occur repetitively. Now everyone has myoclonic jerks. So there's epileptic myoclonus and there's non-epileptic myoclonus. You've all experienced this while you're falling asleep and you have a jerk that will wake you up from sleep. That's normal. And kids have that more. Babies, it's a known entity where they have benign infantile myoclonus. Just because of the immature nervous system, they have those things more frequently. So if you're seeing a few myoclonic jerks that are isolated, that aren't repetitive or becoming more and more frequent, particularly while a child is sleeping or falling asleep, in general, that's not a cause for concern. If you're seeing what look like these myoclonic jerks while someone is awake during the day, if they're repetitive, if they're increasing in frequency, that's another reason why I would contact your friendly neighborhood neurologist to address that and see, are these myoclonic seizures? Does this warrant treatment? Okay. Yes, you can. You can have different. You can have focal, and I'll get into what seizures look like in Mowat-Wilson syndrome in a moment. But you can have focal seizures, atypical absent seizures, myoclonic seizures, and even these other types that I mentioned. Yes.
Maybe a little ahead, normally that's fine, but based on that question about how many seizure types,
Mm-hmm.
is there any sense of, because I know what I've read with Mowat-Wilson syndrome, some of the kids actually, as they get older, do much better in terms of the seizure care. Some
You know, I don't know that answer in Mowat-Wilson syndrome, and I don't know if anyone does. I'll get into the more specifics of epilepsy in Mowat-Wilson syndrome in a moment, so we may kind of get at that question a little bit. But I think it's one thing that would be good to look into further, you know, how people respond, what they respond to, whether or not some new treatments might be worth pursuing for this. So we talked about seizure classification. There's epilepsy, various epilepsy types. You can have, again, focal or generalized forms of epilepsy. You can have combinations of those. In Mowat-Wilson syndrome, frequently you have combinations of focal and generalized seizures. And then epilepsy syndromes, which I think Mowat-Wilson syndrome is its own distinct entity. So the evaluation, we've touched on this some, but the typical evaluation for seizures normally includes some kind of neuroimaging. You all probably experienced that in your family member, not just for seizures, but for other reasons in Mowat-Wilson syndrome. Interestingly, brain malformations, you probably know that we see in Mowat-Wilson syndrome don't necessarily correlate with the epilepsy type or epilepsy severity, but still important to get an image of the brain, and then to do an electroencephalogram if you're concerned someone is having a seizure or has had a seizure. It's important to do an EEG to evaluate for any of those that abnormal activity that's associated with seizures. Yes?
The EEG, do you think in syndromes like this that most of them are seizures, they need the EEG in 2 hours, or maybe it's better to have all the night sleep EEG to determine, because I have 3, my son, they eat the partially and everything is normal, but maybe he's
Right.
coming at night and we don't know, so what do you recommend in syndromes like this?
So in general, if you think someone has had a seizure or is having some seizures, a routine, a brief EEG is probably adequate. But in a case where you think someone might be having subtle seizures, subclinical seizures, or has a regression, a loss of skills, a plateau in development, anything like that, I do think you need an overnight EEG, or at least an EEG that's long enough to record deep sleep, to look for something called ESES, or electrographic status epilepticus of sleep. And that is something that we might be more prone to treat a bit more aggressively, because that pattern, that EEG pattern, can be associated with developmental regression, and is something that you want to identify. It may not be necessary for all cases, but that's something to talk about with your epilepsy specialist. But I'll get into that a little bit more and show some slides of what that ESES pattern looks like. So continuous video EEG is useful for some of those things, for looking for ESES, electrographic status epilepticus of sleep, helpful for confirming seizures if you're uncertain. If you know they're seizures, there's no reason to record these on EEG before treating. You just treat the seizures, and you respond, you change your medications in response to any seizures that you might be seeing. It can be useful if you find that someone is having what are presumed seizures that aren't being adequately controlled by medications, to confirm they are seizures, to decide which medications to use, and sometimes to give medications acutely so you can see what effect your intervention may have, although you may not have an immediate effect with some of these therapies. So specifically talking about Mowat-Wilson syndrome, there's been some good studies on this. Seizures are present in about 3/4 with Mowat-Wilson syndrome. And again, seizure activity, the presence of seizures, the severity or type of seizures doesn't appear to correlate with brain malformations. A study came out in 2013, including 22 patients, all with Mowat-Wilson syndrome proven genetically. Seizure onset occurred fairly early on, so the average was about 15 months old, ranged from 1 to 108 months. And in many cases, that first seizure was triggered by a fever. So there is some fever sensitivity to these seizures, although the subsequent seizures weren't necessarily triggered by fever, obviously. Many had focal seizures initially, some with secondary generalization, some without secondary generalization, and some can typically later progress into other seizure types, including those atypical absence seizures and some myoclonic seizures that we had discussed a few minutes ago. There's also been more severe epilepsy types reported, but not as commonly associated with these EB2 mutations. The initial EEG is often normal or just has some mild background slowing. Background slowing, we just see it's a sort of slowing of background rhythms. There's an expected background frequencies according to a person's developmental age, their developmental stage, their overall age. And in children who have developmental delay, we often see that they're behind in their EEG background rhythms. And that's all that indicates. It doesn't connote any kind of seizure risk. Some had spikes or the things that can be associated with seizures. And one out of these 22 had diffuse spikes during sleep. So frequently, initially, these aren't necessarily, you're not seeing these ESES patterns, you're not seeing a lot of abnormal spike activity on EEG, those things that are more closely associated with seizures. Whereas later on, the EEG changes and does become more active in that you see more, we call spike wave discharges, which become more diffuse, more widespread, and then many had this activity activated during their sleep with almost continuous spike wave activity or this electrographic status epilepticus of sleep. Yes?
Just a quick question. So if, like we haven't had a 24-hour EEG yet, I'm just wondering if we are having seizures during sleep, would an altering of behavior be an indication potentially that there is spike waves happening during sleep?
So one of the symptoms of ESES, this electrographic status epilepticus of sleep, is behavior change. In general, if you see this in just any child, ESES is associated with language regression and behavior change. So if you don't have another good explanation for it, then that's another reason to think about getting an overnight EEG. Great question. Yes?
48 hours.
You don't need a 48-hour, sorry, because just getting sleep is going to be enough. You'll see it on one
No, I don't know.
stage of sleep.
I think our doctor might be doing it at the moment.
Okay.
Because he, like, in the hospital clinical setting, he will not sleep the first 24 hours.
Oh.
Hate it.
Okay.
Is that normal? Is that
I
common?
I really, wow. Okay, that's unusual. But if that's the case, then yeah, probably worth getting a 2-night EEG. Good luck. All right, so this is again from the same study, going over each of these 22 patients who really all had seizures, and of various types. So these are focal seizures, is the FS. Atypical absence is the AA. And then myoclonic seizures you see here in a minority. And many, and this is various ages, are seizure-free with different kinds of medications. I'll get into medications some. But you can see here, valproic acid is probably the most common one prescribed in this country. It's Depakote. Topiramate or Topamax, phenobarbital, Tegretol, carbamazepine, oxcarbazepine, or Trileptal. Levetiracetam or Keppra are the most common ones used. Again, you're seeing a lot of valproic acid. And then some patients require polytherapy or multiple medications if they have more severe seizures. So this is an awake EEG on a 9-year-old patient. Let's see. This is patient C. a 9-year-old patient and an 11-year-old patient during the awake state. So this is a fairly normal appearing background here in the first part of that EEG. And then there's a burst of what we call spike wave discharges. I think that's pretty easy to see. So this is abnormal and the kind of thing that we see that can be associated with seizures. And then if you look at the next slide, wait, no, hold on a second. Sorry, I thought I was jumping into ESES here. This is an atypical absence seizure. So this is a normal background. Each patient here then has a pause in activity, diminished responsiveness during this atypical absence seizure. So that's what that looks like on an EEG. It's atypical because, again, clinically you may not have that complete loss of awareness. You might not have a discrete onset or offset. And what the EEG characteristics that we see are a little bit different than a classic absence seizure. So getting into the mechanisms of what causes seizures in various kinds of genetic syndromes can help us to decide what medications might be best to treat this person or other therapies might be best used. So ZEB2 is a DNA binding transcriptional repressor. It codes for this transcriptional repressor. It probably has multiple different things, but one of the things that it has been shown to do is leads to development of these neural stem cells into interneurons in the deep part of the brain called the striatum. It's important for your coordination of movement, rather than development of these cortical interneurons that have an inhibitory effect on the overall output of the brain. So what happens is you have less inhibition in the cerebral cortex, a part of the brain that generates seizures, because you have less of these interneurons that produce GABA, which is the main inhibitory chemical, the main inhibitory neurotransmitter of the brain. So how might we use this in deciding how to best treat someone who has Mowat-Wilson syndrome and who has epilepsy? Well, again, there's likely multiple other mechanisms here, but if we use this information and what we know clinically about what has been tried in this thus far, medications that potentiate GABA, that act on those GABA receptors to enhance that GABA, that inhibitory response, like Depakote, that's one of the ways that Depakote acts, can help to reduce seizures. There's other medications that act on GABA. There's benzodiazepines, things like Onfi, clobazam, clonazepam. Those have been used some. Phenobarbital does. It's not a great medicine for some other reasons. And many of our medications act on vigabatrin, but those are the main ones that we use are the benzodiazepines like clobazam, clonazepam, or valproic acid. So this is another EEG. You're seeing here on the left, there is an atypical absence seizure. This is during the awake state. So again, you've got a fairly normal appearing background with the rather abrupt onset of this spike wave pattern associated with an episode of staring. That's what we see on that EEG. And then this is the same patient who's asleep. And this continuous spike wave activity, this electrographic status epilepticus of sleep that we can see in a large proportion of people at some point, usually later on, with Mowat-Wilson syndrome. In part B, there was a study, I think, on 5 or 6 patients with Mowat-Wilson syndrome who had this ESES pattern. And some of them, they modified treatment in response to this. There was one patient, this one I'm showing here, who got steroids, who got hydrocortisone, and had a reduction in that spike wave activity during the awake state, but particularly during the asleep state, and seemed to have some clinical improvement too. So I think this is probably worth exploring some more, but my take-home message for this is if your child has a plateau in development, certainly a regression in development, including behavior change, it may be worth doing an overnight EEG. I say you should do an overnight EEG to look for this pattern. and then consider whether or not you might want to change your treatment in response to this. In general, there's a few different treatments that we use for electrographic status epilepticus of sleep, or ESES. Benzodiazepines like clobazam, Valium are tried. Valproic acid or Depakote can be added or optimized. Keppra has been tried, again, therapies that are often used in general for epilepsy. And then steroids are also an option. There's some other things too, but these things all have side effects as well. So it requires careful monitoring for side effects, monitoring of development, behavior, overall outcome, and monitoring of this EEG pattern. So I bring this up a bit cautiously because I think it's not really well known if this is going to be something that kids in general with Mowat-Wilson syndrome might respond to, but it's something that's worth at least thinking about if you're seeing a plateau of regression in development. Yes?
Can an EEG be done under any kind of sedation? Because like once that
Yeah.
no,
Yep. Yeah, so EEGs are often placed under sedation. It can be done. Not typically, but most places have the capability to do it. The trick is in keeping it on. That's often more challenging. But we at Children's National, we have a team for kids who have developmental delay. We walk them through it ahead of time. We kind of go through a dry run, a dress rehearsal for it, so they know what to expect. They know what it's going to look like. We have special hats they put on to try to make it as nice and easy as possible for kids. We work with Child Life at our institution, so we can make it as non-invasive and non-traumatic as possible. Because it's a tough experience for kids to go into the hospital. We've also been able to do there's ways to do outpatient EEGs. We can do like a multiple hour EEG on an outpatient basis, and that might be an option. If you think you can record deep sleep during that, that's also a potential option. But in general, an overnight EEG is probably the best way to go. It can, but if you see someone during that asleep state, it will give you some indication of whether or not you're seeing this pattern. Yes? Okay. Okay. Yeah, so I mean, EEG is not, it's not like a lab test, where there's like a normal range, you get normal, you get abnormal. There's a question about EEG reading and interpretation. So depending on who looks at it, I have seen lots of variability in EEG interpretation. So I'd say you want someone who is EEG and epilepsy trained, who's done this, who has a lot of experience in it, to do that EEG interpretation. But it's not uncommon, even for those of us that do it a lot, to have differences in opinion on kind of subtle things. Usually ESES, you're not going to miss. It sounds like they might be describing this tongue movements, something called glossokinetic artifact, where it can look like you have some slow waves on the temporal parts of that EEG. So those kind of subtle things, there can sometimes be some not disagreements, but differences in opinion on this. And if that is a concern, it might be worth just checking again, repeating again to see if that's still the case. But that would not typically be confused for ESES, I would not think. Yes? It's not usually our first choice for older kids. It is the first choice for neonates who have seizures, for babies in the NICU, because it's been around since 1912. It's been FDA, well, I guess not FDA approved, but it's used here since 1912. So we have lots of experience in using it, particularly in babies. It may not be a great medicine for older kids because there can be some cognitive side effects, some cognitive impact. It's more sedating than some of the medicines, some of the newer medicines that we use. And it can also just take a while to pull someone off phenobarbital. If you stop it abruptly, you can have withdrawal seizures. So there's other things that you might want to try first before going to that. Yeah? Oh. Yeah. So the question about phenobarbital and about status, about trying to come down off of phenobarbital, and that can be a long, arduous process. I'll see it happen that many kids do have what we hope is only a transient increase in seizures as they're weaning off phenobarbital. If that's sustained, or if your child is having status epilepticus, which I'll talk about, definitions of status in a little bit, then it may not be possible unless you can try other therapies. If you find something else that's effective. Whether or not status epilepticus can lead to additional episodes of status, there is this theory, that if you have more and more seizures, that can make you more prone to having seizures. In general, that's not necessarily the case. We know that children that come in with an episode of status epilepticus are more likely to have that in the future, but a lot of that may just be their types of seizure, their propensity to having status epilepticus in the first place. Not necessarily that status begets more episodes of status. There is evidence that status epilepticus can, if it goes on for half an hour or more, can cause scarring in the brain, something we call hippocampal sclerosis in a particular region of the brain. That takes a while to actually develop. And that can lead to other seizure types, particularly temporal lobe seizures. But it's a good question. I think we do try to get control of seizures as best we can so they don't get out of control. Yes?
How common is it to have partial sterilization seizures? Like twin stars have had a seizure and had partial facial sterilization.
Paralysis, yep. So you can have, so the question is about paralysis during a seizure. You can also have it after a seizure. So more frequently it happens as a post-ictal and after seizure phenomenon. We have a name for that. We call that a Todd's paralysis. And that can look a variety of different ways. In general, you can see weakness in the body part of the side of the body that was involved in a focal seizure. And it can last for a long time, hours, sometimes a day. It generally improves over time. So if you see it not improving, or if you see it worsening or kind of coming back over and over again, you might wonder if there were ongoing seizures. And rarely it can happen as a part of a seizure itself. But that's something that can happen. Okay. So we talked about this some, but our general principles for seizure medication, seizure management. For most people who have seizures, most children who have seizures, we don't start a medicine until after the second seizure. For Mowat-Wilson syndrome, I do think it makes sense to start a medication after you see the first seizure because of their risk for ongoing seizures is fairly high. The first medicine that we choose in general, this is for anyone who has epilepsy, works 50% of the time. So there's no guarantee the first medicine that you choose, you probably already know this, you're sitting here, there's no guarantee that the first medicine is going to be effective in controlling seizures. We don't know if it's going to be the best medicine for you or your child. We tend to choose medications that have the fewest side effects. Or if there are side effects, we try to choose side effects that might even be beneficial for some people. Some medications can be more mood stabilizing. They can make you tired, so if you're dosing them at night, in some cases that might be a good thing. So we try to choose medication based on the side effect profile. There's not great head-to-head studies of our anti-seizure medications for most types of epilepsy. So there's not really, in general, any one medicine that stands out above the rest as like the one to start in regards to the effectiveness. Again, for Mowat-Wilson syndrome, I think it looks like many end up on Depakote, may have a decent response to Depakote or valproic acid. Levetiracetam, I think some benzodiazepines, clobazam, Onfi might also be good options, but there's certainly others, and some of that depends on seizure type, on what you're finding on that EEG. There's different reasons to choose those different kinds of medications. But in many cases, it's that side effect profile we look at. Usually we start a medicine. Some we can start fairly quickly. Some we have to start over a much longer period of time. Lamictal or lamotrigine is one of those that it takes a long time to start, because you can have a severe rash with Lamictal. It's your body's immune response to this medicine. And if you very slowly sneak it into someone's body and very slowly increase the dose, although we can see a rash, we don't tend to see that severe rash. If we do see something, we stop it immediately. Most other medicines we can increase over a period of several days to weeks and get someone on a decent dose of medication that would be expected to have a beneficial effect on seizures. But when you do start a medicine, just expect to start at a lower dose and increase gradually to a goal dose. Now, once you reach that goal dose, that may not be the right dose for you or your child. You may need to go up beyond that. So typically, we would continue increasing a medication in response to continued seizures up to the point where we're either seeing side effects, significant side effects from that medicine, or up to the point where we determine that no further increase is going to have any more beneficial effect. So, and usually that's based on weight. So we look at the dose in milligrams per kilogram to determine whether or not any additional increase might be useful. Some of the medicines like Keppra, levetiracetam, have a very wide therapeutic range. So, there's case reports of people getting 10 times the normal dose of levetiracetam or Keppra, and you wouldn't know the difference. It has a very wide therapeutic window. You have others, some of the older ones like Tegretol, Dilantin, that if you exceed a certain level, you can become toxic and dizzy. You can have increases in seizures. Some of the medicines will follow drug levels to look for that, to look for any signs of toxicity. Some medicines we don't follow medication levels. We just look at people based on their clinical response, although in some cases we can get medication levels to help us guide our treatment choices. Changing medicines, we don't abruptly stop one medicine and then start the next one. You'll find that we will usually start another medicine, titrate the dose up until you or your child's on a reasonable dose, and then taper that first medicine down. Reason being because we don't, what you'll find is that seizures can increase in frequency over time. So in many cases, you'll put someone on a medicine. They'll have what looks like a positive response initially, and then at some point, seizures start increasing. They're returning. They're increasing the medicine. Seizures persist. If you then lowered that first medicine as you're increasing the second medicine, and you see seizures stay exactly the same, it's hard then to know if that first medicine was having a positive effect and that second one's also having a positive effect. Maybe reducing the first one and increasing the second one, you're just staying in the same place. So we like to just change one thing at a time, typically. Many people don't respond to just one medicine. Many people need a combination of medicines. And these medicines work in different ways. So we usually try to choose medications that have different mechanisms of action because they can complement one another. They can treat seizures in different ways through different mechanisms. And typically the side effects aren't going to be additive as if you started a medicine like if you were on Dilantin and Tegretol at the same time. They both act on sodium channels. You can see the same side effects from those medicines. So it's not a combination that we would usually use. Our goals of treatment are different for each individual. For some people, for everyone, our first goal is to make someone seizure-free and free of side effects. That's our goal. These seizures, I should also say, you'll see the term anti-epileptic drugs and anti-seizure drugs. I prefer the term anti-seizure medicine because these drugs don't prevent epilepsy. They just, while you're taking it, they hopefully will make you less likely to have a seizure. So they don't do anything to affect future risk for epilepsy, future chance of developing epilepsy. They're not anti-epileptic. So that's our primary goal. If we can't achieve that, we've tried a few different medicines. Someone is still having seizures in Mowat-Wilson syndrome. I would say we need to talk about what our goals for treatment are. I think the next step is if someone is having seizures, we make sure that those seizures aren't interfering with someone's life. So you're not having long seizures. You're not having seizures that are going to take you out of an activity. If you just have a few brief atypical absence seizures a few times per week and return right back to your normal activity, that probably, I would say, won't have a significant impact on a child who also has developmental delay and won't be expected to live independently, to drive and all that. We don't want people to be going into status epilepticus or be having long seizures, to be having seizures that are putting them at risk for injury, for falls, for hitting their head or hurting themselves otherwise. And we'll talk some about SUDEP. I don't know if you've heard about that, but I'll get into that in a bit, and that's another goal, to reduce particularly the grand mal seizures, which do put individuals at higher risk for this entity SUDEP. You should have a seizure action plan for home and for school. So what do you do when you have a seizure? What do teachers, what do school personnel do? How do they respond to different seizure types? And I'll get into that in a moment. And then when do we stop medicines? So for your typical child or adult, once you're seizure-free for 2 years, we will often talk about doing a repeat EEG and tapering down on medications. This may or may not apply to some people with Mowat-Wilson syndrome. I've talked about this some, so this is a slide from 2011. There's a few more medicines here on the list now. So you see a proliferation in medications over time. We had bromide in 1860, phenobarbital in around 1912. Medicines have been added over the years. You see that the pace of drug development has increased really in the 1990s. But these new medicines really aren't any more effective necessarily than the older medicines. They're just different, hopefully, in their side effect profile. For some people, though, you do find the newer medicines can be life-changing for some people when they've tried all these before that. There's other non-medical options. A vagal nerve stimulator, this is just an illustration of what that would look like. So there is, the vagal nerve stimulator is a device that's implanted under the chest wall. This is done with our neurosurgeon. And there's a wire here that goes up from this generator and wraps around the vagus nerve. It's got a couple indications. One is to treat depression, and the other is to treat seizures. And we find that there is a more than 50% reduction in seizures in around 40 to 50% of people who have a VNS. This is not Mowat-Wilson syndrome. This is people in general who have epilepsy. And in many cases, people who have tried multiple different medications prior to that. This doesn't necessarily replace medications. It's not going to cure seizures. In some cases, though, it can allow us to reduce other medicines that might be causing someone significant side effects. It doesn't tend to have the same side effects as medications do, so it's not going to be sedating. It may not, probably won't have some of the behavioral side effects you might see with these medications. You can have cough, you can have changes in voice when the VNS is activated. Risk of surgical complications is actually fairly low, but those are things you want to consider as well. This battery also needs to be replaced around every 5-6 years or so. So something to consider. Yes?
What's your take on that and reducing ESES?
So I don't know if it's been studied in reducing ESES. It is useful for Lennox-Gastaut syndrome, or LGS, which is also associated with very frequent spike wave activity. So it's something maybe to think about, but to my knowledge, it has not been adequately researched. Not to my knowledge, at least.
You want to study
Yeah. All right. I have to ask. Okay. Well, I think these would be good things to look at, right? Because some of you probably have gone through this and have that experience. Yes. Yeah. This is, I know you're working on the registry, so I would encourage you to all participate and encourage everyone you know to participate in collecting this information. I have some experience in helping to kind of build some of these epilepsies. I work with the Rare Epilepsy Network, a couple other different kinds of genetically mediated epilepsy, so I'm happy to help with that if you're interested, but I think we need to look into this. Yeah? Not necessarily. It's probably not a good option for myoclonic seizures. In general, it doesn't work as well for those. But it's used for focal seizures, it's used for atypical absence seizures and other types. And once a couple of medications, a few medications have failed you, it may be worth thinking about this. Yes? Well, you can have an MRI, but it has to be a certain type of MRI with a certain type of head coil. So it does somewhat limit the strength of the magnet and the type of head coil you can use. You can still get MRI, though. Also, if you have any surgeries or anything, it has to be turned off before and turned on afterwards, typically. Same for MRI. You want to turn it off before and turn it back on afterwards. So your neurologist will do that. Okay. Move on. Sure.
Can we get to the cannabinoids?
Yes, we'll get to that. All right, we're going to get to cannabinoids, I think next. So there's also dietary therapies. There's a classic ketogenic diet, which has been around since biblical times, fasting, and does have a place for intractable refractory seizures. It's actually now easier to do than it used to be, because if you Google ketogenic diet, the first things you see are the bodybuilders and the weight loss people who are all doing it. And now there's actually a lot more options out there for people who are on the ketogenic diet, foods that are much more palatable. So it might be worth exploring. We have a dietary therapies clinic at Children's National, and we have a dietitian who works with families very closely, epileptologists who are experienced in this, who can also help to guide things, monitor laboratories. There are side effects for this too, so something important to keep in mind. And there's variations on the ketogenic diet. There's a few different ones listed here, which may also potentially be effective for seizures. All right, cannabinoids. So I probably shouldn't have put this slide in first. It's not it is, so the risks of cannabis have really, in large part, it's been difficult to do research on this because it is so tightly regulated. We know there are some neuropsychological risks of marijuana. There was a good study, it came out, I think it was in Pediatrics in 2012, that very carefully controlled for education, for socioeconomic status, all kinds of levels of functioning, and found that regular cannabis users in adolescence had worse neuropsychological function, and stopping it didn't necessarily fully restore that. So we know marijuana is bad for the adolescent brain, but we're not, in most cases, talking about using medical marijuana for epilepsy. We're talking about cannabidiol, which I'll get into in a moment. You can also have episodes of psychosis from medical marijuana. and THC, the psychoactive component of marijuana, may be able to provoke seizures. I'd also say that in the studies on cannabidiol, which were just reported recently, there were some who actually had an increase in seizures. So cannabidiol may, in some cases, actually also be associated with an increase in seizures, although there may be some benefits to cannabidiol. So these are the early studies. I'll kind of skip over this because this is what a lot of the newer studies were based on, and they weren't very well designed research. So our gold standard for doing drug research is to do a double-blind, placebo-controlled, randomized controlled trial where you give half of people placebo, you give half of people drug. Neither the patients, the parents, nor the doctors know what either group is taking. You do the evaluation and you unblind later on. So you control for all those different variables and are just looking at the response to placebo versus response to drug. You'd be surprised, for epilepsy studies, the placebo response generally ranges between about 10 and 30% for people who have reduced seizures. And you'd ask, why is that? There's a few reasons for that, which I won't get into. But it's important to do these placebo-controlled trials for that reason, because we do see a significant placebo response in these medication trials. Some of it is recall bias, and reporting bias. Some of it is just natural fluctuations in seizure frequency. You probably enter studies at a time when your seizures are happening more frequently. But it's important to do these trials. So cannabidiol was mostly used initially in Dravet syndrome, which is a severe epilepsy that's due to mutations in this sodium channel gene, SCN1A, and some other types of epilepsy. And now we actually have randomized controlled trials in Dravet syndrome. It's been reported recently, and Lennox-Gastaut syndrome. I'll get back to this in a moment. This just came out from Oren Davinsky at NYU. It's a multi-center study in Dravet syndrome. This is the pill form of cannabidiol. And there was a reduction in seizures and improved overall condition of people. Some things that people have talked to me about, that people you're brighter, you're more interactive, so that it seemed to be not just better in regards to seizures, but in other things as well with Dravet syndrome. There's also, they're looking at the data on Lennox-Gastaut syndrome, and there's a couple studies coming out with that, and one more study coming out with Dravet syndrome. The idea is that they're going to have FDA approval hopefully soon for this drug, this cannabidiol in pill form. There were some side effects for this. Diarrhea, vomiting, fatigue, sleepiness. Some did have an increase in seizures. And it's been studied, although not in the randomized controlled trial. This is an open label study, so you know what you're taking or you know what you're giving your child. But there did seem to be a reduction in seizures. The average reduction was about a third of those motor seizures, meaning shaking seizures, in kids who had other forms of refractory epilepsy. So hopefully we'll have more studies coming out on people who have other forms of intractable epilepsy besides Lennox-Gastaut syndrome and Dravet syndrome, but that's what's being looked at right now. So let's go back here. What many people have right now, if you're not in a study, is hemp oil or cannabidiol oil. And I have a number of patients who have tried that. I don't necessarily advise people take it, but I don't advise people not take it, I guess. If you tried multiple different medications for epilepsy and they have not been adequately effective, I think if I were a parent, I would probably try it myself as well. But you have to be aware it's not the hemp oil, the cannabidiol oil hasn't been as rigorously tested as some of these medications. So I would use caution if you do use it. There's lots of different companies that make it. Some are more reputable than others, so I'd encourage you, if that's something you're interested in looking into, to talk with other families who have used it, to see which company they've used. Really do some research, some investigation. Talk to your neurologist about it once you've looked into this. You need to make sure, that they do the quality control, that they're reporting on how much cannabidiol is actually in their compound, The FDA came out with a report in 2016 that showed that a number of different companies that sell this, not some of the ones that most of the families that I've worked with have generally used, but a number of companies actually, they don't contain any cannabidiol at all, or they contain much lower amounts than they actually report. So you need to make sure they're doing the quality control, investigating how much cannabidiol is in there, and be aware that the percent of cannabidiol can change from batch to batch. I'd also say that if it is something you're interested in doing, check labs afterwards, okay? So it can change medication levels. We know this for things like clobazam, it changes Depakote, changes some other medication levels too. So get some baseline medication levels. Once you've been on the drug for about a month, repeat those things. I usually get a blood count, I get a metabolic panel, I look at liver function tests, in part because of the cannabidiol trial, show that some did have elevations in those liver enzymes. So it's important to monitor those things. So I'd say, see a neurologist who's willing to talk with you about this some. I don't think you're going to find many neurologists who necessarily prescribe it, but I think you want to see someone who is willing to discuss it and advise you some on how to use it safely. And it's something that you should do with some medical guidance. Although I can't say to you, which company to go with, which one to use, how much to use exactly, because the data is not out there, and it's different for each company. Questions on cannabidiol? Yes.
There's any type of monitor that you use when they are sleeping? You know if there's some...
I'm going to talk about that in a moment. Yes, so there's a question about using a monitor while people are sleeping to know if they're having seizures. Now, I'll get into that. So maybe I'll move into the last part of the talk since we've just got a few minutes left.
Sorry, real quick.
Yes.
Would the oil be a substitute to clobazam, that type of thing, or would you use that in conjunction?
I would use it in conjunction with, if you do think about tapering medications at some point, I think it's reasonable to consider, but I at least initially would try it with other medications that have, really have evidence thus far for use in epilepsy. Yes?
Along the same lines, do you have anyone who, we have a lot of sleeplessness, and I think it's from the Depakote.
Okay.
Do you have anyone who uses that liquid at night?
For sleep. I can't say necessarily just for sleep. I'm not sure about that. There's other things that can be, tried for sleep. I'm sure people have tried, we've gone through a bunch of them, but that's worth thinking about. Yes?
The oil does not have to euphoric as medical marijuana.
Right. So some oils contain a small amount of THC. You can't contain that much just by government regulations. But I would say if you do use something, I'd probably stick with the cannabidiol that does have some evidence in different kinds of epilepsy. But yeah, it doesn't have that. It's not a psychoactive medicine necessarily. It's not going to make you high. Yeah, right. Oh, how many patients do I have that have tried it? So those have told me, and I'm pretty open, and I'm pretty open to it. I talk about this usually once or twice a day. I want to say I have about 15 that are on it or have tried it. Of those 15, I have one who has had a remarkable response to it. And it's hard, definitely can't argue with it. It has had really has changed. Her seizures has reduced them drastically, such as she's like having none. This is not Mowat-Wilson syndrome. This is another child who has a brain malformation and deletion syndrome.
What kind of seizures did that individual have?
Focal. Mm-hmm. But it's different for each kid, I think. I think there's other things coming out of this, and even for a uniform epilepsy like Dravet syndrome, where it's due to sodium channel mutations, you have some that respond to it and some that don't. Yes?
So you were talking about CBDs
Right.
Do you have any experience with anybody trying THC, and would that have the same kind of effect, or do you not know?
I just don't think there's enough evidence to support the use of THC for epilepsy, and actually some evidence against using THC or medical marijuana for epilepsy. I think cannabidiol is what's being focused on right now. I think it's what's being studied. I don't know if people are going to be looking actually into medical marijuana by itself for epilepsy much because of some of the regulations and because of all the inertia now that's behind cannabidiol, which has showed some positive effect. Yes? Hmm. Is that a common side effect of Depakote? Or yeah, so, gosh. Depakote is felt to be one of those medicines that's less sedating. It's kind of when compared to the older medicines. But it can have that effect on some kids. It's used for headaches in some cases. It's used as a mood stabilizer in some cases. But some kids just don't have that response to it. If it's, again, these medicines can have the kids can react to these things differently. So if it's not having a positive effect, then I'd think about something else, think about transitioning. Because it's important to not just treat the seizures if you're having horrible side effects from a medicine. Sometimes those are worse than the actual seizures that you're treating. Let me move on to the last part here, in the last couple of minutes. So, I think this is it. All right, so other seizure management issues. Seizure precautions I go over. You don't want to leave anyone in water or a bathtub by themselves. Showering's fine, but you just don't want to leave anyone in water in case they should pass out. There's a huge risk for drowning. Acute seizure management, I'll get into. I'll go over the seizure action plan. Avoiding triggers, so common triggers. To the extent you can avoid sleep deprivation and illness, go for it. Those aren't always possible to avoid. Medications like Benadryl, so diphenhydramine, Atarax, your sedating antihistamines can increase your risk for seizures, can lower the seizure threshold. And people are already prone to seizures. Yes? What? Melatonin's okay. Melatonin looks like it should be safe. So most medicines are all right if they don't interfere with your seizure medications. But I say avoid some of these, particularly the sedating antihistamines. The non-sedating ones like Claritin seem to be safer. Miss medicine, so if you miss a medicine, when you miss a medicine, it happens. I usually tell people if it's shortly after, you can just go ahead and give it. If it's right before the next dose is due, depending on what the medication is, usually you would just then go ahead and give that next dose and not necessarily give a double dose, but it does somewhat depend on what medication you're taking. So probably good to just kind of establish those rules with your neurologist and ask when it happens. It's going to happen. What do you do? Just so you don't have to scramble and then try to reach somebody over the phone, which can be hard to do sometimes during a busy clinic day to get back to people. And then seizure detection or monitoring. So there are some devices out there now that can help with seizure detection. There's some watches, Apple Watch actually, if you have generalized tonic-clonic seizures or grand mal seizures. There's a study out there, I think it gives you a free Apple Watch actually, that uses the watch to detect I believe it's a movement associated with convulsive generalized tonic-clonic seizures. There's some other devices out there, one called the Embrace Watch, there's a few others that, again, detect movement. There's devices that can detect changes in sweat and skin conductance, and that can also be associated with seizures, and heart rate. All sorts of devices like that out there that are being investigated looking at seizure detection. What most people recommend, people that do this and research risks of seizures, say, are to have some kind of direct monitoring. So I'd say either, and some people, they sleep in the same room. I think that's not always a great solution, not always extremely feasible. What I recommend and what the experts for this SUDEP or sudden unexpected death in epilepsy recommend is to just have like a baby monitor, some sort of video and audio monitor so that you would hear or see a grand mal seizure. Have any of you heard of SUDEP, or sudden unexpected death in epilepsy? So it goes by the name both of sudden unexplained or unexpected death in epilepsy. It is rare in kids. In general, in kids with epilepsy, this unexplained, unexpected death happens in 2 out of 10,000 children with epilepsy. So it's really rare. In adults, that risk can actually go up a lot. So in adults who have uncontrolled grand mal or generalized tonic-clonic seizures, and uncontrolled means 3 or more per year. If they're, you're non-compliant with medications, male, and have nighttime seizures, the risk can be as high as 1 in 100 per year. So something about the transition to adulthood, about these grand mal seizures, does increase that risk considerably. We don't know why that is. We don't know if it's cardiac mechanisms. I'm researching that some, or if it's something that has to do with the brain itself. But this is the reason why people usually worry about seizures. So again, the risk is rare in kids, but the people that study it say some kind of monitor like that is probably the best way to look for seizures right now. There's also anti-suffocation pillows. Things you can find online that may reduce that risk if you have a seizure. You're passed out, you're not able to wake yourself up adequately. You want to make sure that you're not going to block the airway by having your head down in a pillow. So I think it's probably worthwhile looking into one of those. So seizure dogs, not all of them work, but it's probably worth looking into. But they don't all necessarily actually detect seizures. I do, yeah, a few. I think the data is around like 10% of cases, 10%, perhaps a bit higher, work to detect seizures. Okay, so in the last couple of minutes, maybe we'll get into the last. So it's good to have a seizure action plan. You might have seen this. This is the Epilepsy Foundation. Most of us use this about what you would do at school. So it's got your name, contact information, medical history, seizure type, description, frequency, what to do when a seizure happens, when to call 911, when your child can stay in class, when to go home. You can find this on the Epilepsy Foundation website. On my slides, I have a couple of links, including one to the Epilepsy Foundation. And then if you have any emergency medications, so this is another important thing to discuss, is when to intervene and what to intervene with. So when you have a seizure, if you have it's particularly a grand mal seizure, you don't want to put anything in someone's mouth because of the risk of choking on that. You're not going to swallow your tongue. For some of the more subtle seizures, the smaller ones, you can use tablets, like a dissolvable tablet, to stop a long focal seizure. And that may be an option, but again, for the grand mal seizures, you don't want to put anything in the mouth. There's a medication called Diastat, which is approved here to stop seizures, to stop status epilepticus, and to prevent the need to go to the hospital in some cases. Although if you're using it for the first time, I usually tell people call 911 if you have to give Diastat. It's a rectal medication meant to interrupt the seizure, last longer than 5 minutes. Reason being, status epilepticus is a seizure lasting longer than 30 minutes. We use that definition because that's when a seizure has been shown to potentially cause scarring in the brain, damage to the brain, and other effects as well. We say to people to give the medicine, the Diastat, after a 5-minute grand mal seizure, because if a seizure lasts more than 5 minutes, in a kid it's more like 5 to 10 minutes, but if it lasts more than 5 minutes, it's more likely to continue at that point unless you intervene. Most seizures stop before 5 minutes. Yes?
Is there a potential harm to giving too much Diastat?
Yes.
Because like my son's already had 4 doses of it since January. And
Oh.
he's also had like 6 doses of Ativan.
So as far as we know, there's no like cumulative effect of these benzodiazepines or Diastat. You can give 1 to 2 doses of Diastat typically. Acutely, it can cause respiratory depression, blood pressure, and cardiovascular changes, more drooling. It's really more the airway and the breathing risk. with diastat, but as far as long-term, not really any known effects. If you use it multiple times in a week, you can have some withdrawal from it. If you're using it so consistently, like once a day or once every other day, you are going to build up some tolerance to that benzo. It is. It's rectal Valium. Yeah, exactly. Well, they have the same side effects, so they are going to have, and you're going to build up tolerance to those things if used in combination. So yeah, there's midazolam, can be used nasally. It's not, you have to get it compounded here. It can be used buccally or in the cheek, midazolam. There's rectal Valium, there's oral Valium, there's clonazepam, which comes in a disintegrating tablet. There's Ativan, and then the EMS, the emergency medical personnel, can use different types. Status is more of a risk for the generalized convulsive, the shaking status. And the risk really increases after about 30 minutes. So if you look at what happens here, after 30 minutes, you see some changes in neurotransmitter systems. You see the status become more refractory to treatment because you no longer have these GABA receptors, these inhibitory neurotransmitter receptors expressed on the neurons. They get internalized, so you're not going to respond to your Ativan or your other medicines like that as well. You may go from having generalized convulsions or shaking to more erratic myoclonic jerks, as we have what's called this electromechanical dissociation. You're seeing that status on the EEG, but you're no longer seeing those physical manifestations as much or as consistently as the status progresses. You're seeing decreased cardiac output, blood glucose, oxygenation, and that risk for brain damage goes up, particularly with convulsive status, starting sometime after 30 minutes. So that's why it becomes a risk at that point. Other comorbidities and complications of epilepsy, we talked about SUDEP, that's the main thing. I think we've gotten into a lot of these things and reasons for treatment of epilepsy. And I think that's it. Oh, vaccinations. So again, this is true for people with epilepsy in general. If you look at risk for seizures, there's actually a higher risk if you delay immunizations of febrile seizures, probably because febrile seizures, the peak incidence of febrile seizures is around 2 or 2.5 years old. So if you're waiting to do those 1-year immunizations until 2 years old or later, there is going to be an increased risk for a febrile seizure associated with immunizations. We know it can happen. This vaccine encephalopathy, a lot of those cases are actually genetically mediated epilepsies like SCN1A. So I'm not sure if that relationship holds up. Vaccines don't cause epilepsy. And again, but they can result in febrile seizures. Let's skip through this. But I would say if you have uncontrolled seizures, it's probably best to get them under control as best you can before, if you are have immunizations that are pending. It's probably best to try to get things under a little better control before you give something that is known to be associated with febrile seizures. I think that might make sense. So I think we've covered a lot here. Had some great questions. I want to see if there's any more questions right now. I think we got to wrap up, but I'll take a couple more questions at the end. Yes?
My question is about, my son is on trial for 3 years and he is genetically predisposition to immune deficiency, which causes CVID. So now he has to have monthly blood infusions as well.
Oh.
Is that a common thing for some of these medications to trigger or cause some of those immune deficiencies?
No, it's not. So that's not really something we usually see. You can see allergic response, usually some kind of allergic response, a skin rash or other reaction like that, but not CVID. That would be pretty rare. Yes?
Hey, about the status epilepticus, you said anything lasting longer than 30 minutes.
Mm-hmm.
My son was in the PICU for about 7 or 8 days, and we were trying to get him to stop having seizures. And so you said that it could cause scarring on the brain, and that may change the type of seizure he'll have in the future, or can it change his comprehension? And I mean, how
Yeah.
much will it affect him? And will that also maybe affect the possibility of him having more manageable epilepsy, in adulthood?
So it's a tough question to answer. It's a good question. So with ongoing seizures or status epilepticus, how might that change the epilepsy type, cognition, risk for future seizures? So the status is known to be associated with hippocampal sclerosis or scarring in that what's called the temporal lobe of the brain, and later development of temporal lobe epilepsy. If you look at how long it takes to develop after an episode of status epilepticus, these are kids who have prolonged febrile seizures, so these are young kids. The average duration, latency to develop temporal lobe epilepsy is 8 years. So it can take a long time actually to develop a temporal lobe epilepsy related to an episode of status epilepticus. Temporal lobe epilepsy is a focal epilepsy. It looks a little bit different. It's the classic abdominal rising sensation, deja vu, a loss of contact, with things around you, the orofacial automatisms where you're just kind of making these chewing movements or tongue movements. And you can have temporal lobe seizures for other reasons too. But you should see then scarring in the hippocampus on an MRI. So that's something that may be worth looking at the MRI to see this. I've seen other things too. I've seen kids who've had like progressive atrophy of the overall brain after they've had prolonged episodes of status, are very difficult to control status epilepticus in an ICU setting. So clearly you can have other damaging effects on the brain. But steroids can also transiently reduce the overall brain volume. So you have to think about these things, about what effect medications have, what effect that the actual seizures themselves are having. Yes.
You mentioned the scarring on the brain takes a long time to develop. Over what period of time do you see that scarring?
It's variable, but right, when you do these MRI studies, I have to look back at the data again. It takes on the order of months to years to see. It's from the cases I can recall in the case series that are published out there. What I've seen is repeating things in about 6 months or so, and you might see some signs of it as early as a few months afterwards.
If you don't, the last severe seizure my daughter had, one of several, lasted 29 continuous hours. And then they did another, I think we did an MRI shortly after that, but there was any scarring at that moment. But I'm just wondering if I need to do another one post that to see.
Yeah, to compare. So that may be worth considering. If you did one right away, you may not see those effects until a little bit later on. If you're seeing a change in seizures, if you're seeing them become more frequent, you're seeing a change in cognition or development, probably worth repeating that at some point to see if that's had an effect.